Good afternoon to all. A very warm welcome to all of you for joining us today.
Ready.
On behalf of Neurological Society of India, I am Dr. Sachin Jose, political consultant neurosurgeon at NSI Hospital, Ernakulam. And it's my absolute privilege to welcome you to the NSI webinar on a highly relevant and multidisciplinary theme, management of spasticity. Spasticity presents a complex clinical challenge that requires a cohesive, multifaceted approach. To unpack these complexities, we are incredibly fortunate today to bring together a stellar global lineup of experts, ranging from pediatric and adult neurosurgery to neurology and orthopedic surgery, who will share their immense expertise on everything from medical intricacies to advanced surgical interventions. I have the privilege of introducing the moderator for today, Dr. Matthew Abraham. He is currently the head of Department of Neurosurgery at NSI Hospital, Kochi. He has been faculty in Sri Chitra Institute of Medical Sciences since 2003 and was head of the department since 2017 before taking over at the helm of NSI Hospital in 2022. He has special interest in epilepsy, vascular and skull-base surgery and have published more than 100 papers in various international and national journals. He is the current convener of webinar committee as well as an EC member of the NSI. Welcome, sir, and thank you for joining us this evening.
Thank you, Dr. Sachin.
And I invite Dr. Matthew to introduce the panelists for today.
We have two distinguished panelists, expert panelists to guide us through this entire session. It's a highly specialized field. The first panel is Dr. Anirudh Kumar Purohit. No words to describe him. He is an authority in spasticity in India. He's so devoted to that topic. If you know, it's 3 o'clock in California, where he's speaking from now, and we can see the commitment. And he has been the first person to log in also. He was the former professor and head of the department of NIMS, Hyderabad. He was a senior consultant, but currently his current position is he's a senior consultant in Aster Prime Hospital, Hyderabad. He's a member of the American Academy of Cerebral Palsy, Indian Academy of Pediatrics, and many other neurosurgical organizations in the country. He's a founder member of the Indian Academy of Cerebral Palsy and Indian Family of Cerebral Palsy. He's the editor of the Indian Journal for Cerebral Palsy. He has got the prestigious national, he has several prestigious national awards. He is recipient of numerous gold medals, orations, and he has been publicly recognized for his work in spasticity. Besides spasticity, his other field of interest is humor and health, and also the neurology of humor. He's several publications. He's the author of many textbooks, like several chapters. He has published more than 150 articles in index journals. He's a writer of the book Cerebral Palsy, Gyan Ghosh, Pahela Vijay Kadam, that is published in 2008. He will be guiding us today. He will give an introductory remark, and also he will give his comments at the end. Our second panelist is Dr. Shibu Pillai, a great friend of ours, my senior, and he's currently senior consultant in neurosurgery in Narayana Health Institute, Bangalore. He had completed his MCH in neurosurgery from NIMHANS. He got the gold medal for the best outgoing student in the year in which when he passed out. He has several international fellowships: pediatric neurosurgery fellowship from British Columbia Children's Hospital, Vancouver, Canada; neurotrauma fellowship from Baylor College of Medicine, Houston, Texas. He's more than 30 years experience. His fields of interest is complex cranial, spinal, pediatric, and functional neurosurgery. Welcome you. I'd like to welcome you to this gathering. I would like to request Dr. Purohit to give an introduction to this topic.
Thank you, Dr. Matthew, for such a warm introduction and also my extracurricular activity, that is the humor, a combination of my left brain, the neuroscience, and right brain, the literature, the humor. I'm very much impressed that today we have our uh, guest speaker, Dr. Pettorini. Perhaps my pronunciation is correct or not, but it's so good of NSI that we have invited such a experienced one of the uh, pediatric neurosurgeon from the UK, and we will perhaps developing now a new association with the UK too. And we had our initial association with Dr. W.J. Peacock from Los Angeles in 1988. And then our journey in the field of spasticity began. So let me talk to you regarding our view of spasticity. And please remember the dystonia is very much accompanied with the spasticity. And usually in cerebral palsy, you may not find a pure spastic uh, children with spasticity. Usually it is a mixed one, and there may be an associated many other disorders like the mental subnormality, the vision, the seizures, speech, etc. So we have to have a global view regarding approach to them for this global damage to the developing brain. However, we also have to keep in mind regarding the other than the cerebral palsy, for example, in the adults also when spinal injury occurs or some head injury in the adults, and some of the progressive disorder, but they may be too slow, and in them also we may have to think of that how this spasticity and or dystonia has to be managed. So we developed actually the Indian family of cerebral palsy in 1994 to bring a lot of awareness in India. And then we developed the what is called as the Indian Academy of Cerebral Palsy to bring all kinds of the methods of management of cerebral palsy in India, because it is not only allopathy, there are other associated or we can say additional or alternative therapies are also in vogue in India. So keeping that in mind, we developed in 2004 the Indian Academy of Cerebral Palsy, a combination of families with the academicians, and with that we thought that in our country how best we can bring up a scientific approach to the cerebral palsy and any other causes of this spasticity and dystonia. Because one thing which has always I have been thinking about it when we have seen the families, that the families are confused as what is best for their child, and the professional are confused or biased with what they know. So anyone who knows about particular method of treatment, he or she thinks that this is the best one which with which I can treat. But then cerebral palsy being a global damage to the brain, and then not only motor disorder, there are associated disorders, everything has to be addressed in them. So we started our journey, and let me show you first the how we have to think about managing them by understanding the pathophysiology of cerebral palsy. So as we all know that it is the non-progressive motor disorder due to damage to the developing brain. In a little poetic style, I have mentioned it. Non-progressive motor disorder due to damage to developing brain. And all the inhibition which is coming from the suprasegmental flow of the impulses, which acts on the anterior horn cell, and we know that it is the alpha neuron, alpha motor neuron, which by nature all the time is firing on the muscle anterior root, and then it makes the peripheral nerve, and then goes to the myoneural junction, and then intrafusal and extrafusal phenomenon, which electrical activities which occurs over there. So what we always treated that this is a monosynaptic myotatic spinal reflex arch. By nature it is a facilitatory, and it is the inhibition which comes from above, suprasegmental, controls this segmental control of it. Now, as we all know that in polio there will be damage to the anterior horn cells, and then there will be flaccidity or hypotonia. Now, cerebral palsy, or we can say spasticity, is exactly opposite of that. That instead of they being damaged by the virus, now they are firing a lot on the muscle, and this continuous firing in normally by the Renshaw cells and the internatural neuron, they too control the firing of it. Now, what is this reflex arch? Is the posterior root, anterior root, and then motor branch and the motor fascicles, and this is the spinal reflex arch. So let's see at all these levels how we can act to modulate, control, or relieve the spasticity. So in general, you can see this is the non-ablative procedures, and these are the ablative procedures. In a non-ablative, done can be undone is deep brain stimulation, spinal cord stimulation, intrathecal baclofen, that is what in the spinal level. So these all are the in vogue non-ablative procedures. But then what are the ablative procedures which are done, cannot be undone, is deep brain lesioning. And we know that there is what is called as this selective posterior or selective dorsal rhizotomy and selective motor fasciculotomy. Please remember there can be an anterior rhizotomy also, and this is the selective motor fasciculotomy, which in our journey we started a little later. After we developed, we started practicing rhizotomy. And you can know the botulinum toxin, this can be a little bit of confusion whether it is a ablative or it is a non-ablative, because in general the non-ablative means we can modulate it, increase or decrease the intensity, and depending on that we can modulate the. But in botulinum toxin, once you inject it, yes, you can't do undo. But then one thing is that there is lot of recurrence about the spasticity following this. So there is an advantage of this recurrence also, which we will discuss a little later. Then so many soft tissue release surgeries or bony surgeries is an orthopedic part of the spasticity management. Now let's see, keeping these two in mind, we have to think of that how the medical treatment can also work on this, how the physiotherapy, occupational therapy, orthotic, many of these measures have to be kept in our mind. So let me give an overview of these various management steps and options for persons with spasticity and or dystonia. Now, let me just check. Yeah. So please remember that either it will be a focal spasticity or it can be a diffuse spasticity. So keep these two in mind. Although there are many variables of even the focal, it can be just a segmental which can affect only one part of one limb. So that can be a segmental. And diffuse one, you can understand that either diffusely affecting both the lower limbs or diffusely affecting whole body. So let me just tell you a little bit about the my journey, and that is how we started developing in our country through Indian family as well as Indian academy. that selective dorsal rhizotomy is the procedure where we selectively select the posterior rootlets because there will be a different current will be passing through that, and that was what in 1988 we started with the help of Dr. W.J. Peacock in Hyderabad. And now that is an ideal case is the one who is having spastic diplegia and a good motivation with a spastic gait and no contractures in a preschool child. But I must tell you that in my all these years of practice of 28 years, I have found very few cases of an ideal spastic diplegic cerebral palsy child which fits for the selective dorsal rhizotomy, because when they are still walking, even say preschool means at the age of 4 years, nobody is bothered about that what will happen with the spurt of growth, what will happen to the complications of spasticity. So we in India, actually I can say that we hardly get the ideal cases. So then we were wondering that what to do. So we had many modifications of selective dorsal rhizotomy, which our guest speaker most probably will talk in detail, that so many modifications of posterior or dorsal rhizotomy and ventral or anterior rhizotomy and extend from L2 to S2, or we can modify that one. Meanwhile, we realized that what to do for the upper limbs. So we did a few of the selective, cervical selective dorsal rhizotomy, but we were not very happy that exposing the cord over there. But then what to do about the upper limbs and in quadriparetic as well as the hemiparetic. And then in 1993, we developed selective motor fasciculotomy for the focal spasticity. But then we also realized that it is not only spasticity, this procedure can be considered for dystonic children, also children with dystonia, and especially the segmental dystonia, say for example, only upper limb is having the dystonia. So it has helped for the upper limb spasticity relief by the musculocutaneous, median, ulnar nerve, and later on we started doing for the obturator, sciatic, and the tibial nerve selective motor fasciculotomy. I must say that selective motor fasciculotomy is the word which we have coined, and in 1998 Acta Neurochirurgica considered it and published this. Actually, it is a selective neurotomy, but then instead of a neurotomy mindset of a surgeon, we thought, no, they should think about it is a fascicles which we have to cut, which are hyperactive. So this is how it was accepted, and now most of our publications go with the selective motor fasciculotomy. So somehow we could solve the problem of the focal spasticity, say for example, focal in the equinus, only equinus, say maybe equinus only on one side. So that way, focal diffuse spasticity problem is solved, and then focal spasticity and dystonia problem is solved. But then we were getting the adults also with a diffuse quadriparetic one, and considered that having also dystonia, what to do for these cases. And then the time came where we were thinking about intrathecal baclofen pump, and luckily it came into the market, and we then started having intrathecal baclofen pump. Please remember, the intrathecal baclofen pump is for diffuse spasticity, maybe diplegic or quadriplegic, but we are more happy when there are a lot of spasms or dystonia. In those cases, yes, one can go for the intrathecal baclofen pump. But I know that this is in vogue in USA now. A lot many children, they undergo with the intrathecal baclofen pump instead of rhizotomy. But these numbers keep coming and again getting into the rhizotomy. Now the thing is that in 1998 I went to New York, and Dr. Walsh was doing a lot of spinal cord stimulation. So we did discuss, but very late it has come in vogue, and I have no experience of it. But yes, spinal cord stimulation can also help in spasticity, dystonia, and the pain management. So this is the how these two things are also, as well as we have some of the surgeons in our country also, they do deep brain stimulation. But usually when they are having a hemidystonia, and especially when there is a pure dystonia, not because of the cerebral palsy but because of many other reasons, yes, that is that unilateral deep brain stimulation is likely to improve their condition very good. When we were talking about putting the both side the electrodes and relieving the diffuse problem, usually the families denied for acting or operating on the brain, they preferred the spine, and therefore we have more number of cases with the intrathecal baclofen pump insertion. So it, when in dystonia we cannot do rhizotomy, no, but in dystonia, spastic dystonia, which is common in cerebral palsy, we do intrathecal baclofen mostly for the diffuse person, but then a management, recurring injections of the baclofen, etc. So many other things, intricacies are there in India, especially because we have to remove in few of the cases the pump because of the geographical constraints. So when all these things we were doing, there were cases with the contractures also. So some of the orthopedic procedures we were doing, and later with the help of the many other orthopedic surgeons in our country, and especially I should say Dr. Tarlagda from Mumbai, and Dr. Johari, and now recently one of my colleague is Dr. Pawan Sadhwani, we have added a lot of orthopedic procedures in our management of these children with cerebral palsy. I must say that intrathecal baclofen is very helpful for the adults. Recently, say for example, we have inserted it into a thoracic disc problem post-operatively, was having lot of spasms at the age of 62 years. So I'm just telling the other than the cerebral palsy, there are cases where in the adults too, we can go for the intrathecal baclofen pump, especially when spasms and dystonia are also associated with the diffuse involvement. So we have talked about these non-ablative procedures. We have talked about selective posterior rhizotomies, SMF, and then stereotactic deep brain lesioning. And my colleague will also talk about orthopedic procedures. But please remember, this is the mainstay of the management of these cases, because we as a surgeons or as a physician can relieve spasticity, but the functional improvement, the power to bring, is possible with the help of the physical therapies. So this is one of the most important aspect which usually is not being looked after by many clinicians, that how best we have to train the muscles once we have removed the spasticity, that is the break, and then we can train them. So I have given you an overview in which the Dr. Lokesh Lingappa is likely to talk a lot good about the medications. And now regarding the botulinum toxin is another interesting part. So it can help, like focal injections of neural blocks can tell you to know whether you should go for an ablative procedure or not, with the temporarily blocking the neural impulses. So we do say, for example, in the obturator nerves, where we are not very sure that after ablative procedure he is likely to walk or remain better or not, or we are going to lose the hip control. So sometimes these kind of neural blocks will help. And even the botulinum toxin and phenol injections are going to help. Say for example, at the very young age, when we inject it, say 3 years or 4 years, and then we give the physiotherapy. We perform physiotherapy, occupational therapy. Now, this is complementary to physiotherapy when there is a severe spasticity, child is not cooperative because of the severe tightness, and for a surgeon it is helpful in the sense that you know that after improving control now you may be able to go for a permanent relief of it if it recurrence occurs. So this is an overview from our point of view, but then today much more emphasis will be given on the selective dorsal rhizotomy, and then we will have the discussion. This is just a glimpse of the selective dorsal or posterior rhizotomy. These are the posterior root, and this is anterior root, around 50 to 70% ablation. In some cases, we will let you know that a little bit of anterior rhizotomy also we perform in some cases. We'll discuss in what cases we have to do that one. And luckily, there are a lot many positive side effects also. So we will see in the end to discuss regarding that. And this is in the popliteal fossa. We have opened the tibial nerve, and this is going to medial gastrocnemius. This branch is going to lateral gastrocnemius, and this is the soleus branch from the main trunk. So we can relieve the focal spasticity, inversion, toe flexion, equinus, depending on how severe and what element is present. This is just a glimpse of it. Not only the tibial, sciatic, and in upper limb musculocutaneous, as well as median nerve, which is very common because of the pronator spasticity is very common if the upper limbs are involved. And then wrist flexion by median and ulnar nerve. So these are the focal, as well as we are very happy with the segmental and focal dystonia by performing selective motor fasciculotomy. Please remember, this is the word which I have coined, but its other name is selective neurotomy. And we are happy with Dr. Sindhu, who had a lot of good publications, and we read his literature, and based on that we expanded our experience. So to summarize, these are the non-ablative procedures: deep brain stimulation, spinal cord stimulation, intrathecal baclofen, and then this is actually the ablative procedure. And here one can consider about the botulinum toxin also, selective motor fasciculotomy. This is the peripheral nerve. In the peripheral nerve, we have to take the motor branch and then go for the ablation of the fascicles, or at myoneural junction, botulinum toxin. And dorsal root is selective posterior selective dorsal rhizotomy, and many orthopedic procedures can help into it. Now, one of the most important thing in overall, one has to look into the age of the child also, other than the topography and pathophysiology of the impairments, spasticity, dystonia. But please remember, in ataxia, rhizotomy is contraindicated. So, therapies, and then non-ablative, ablative, orthopedic, this is for, say, till the teenagers, something keep going on. We believe in orthoplastic neuro, multi-level, multi-stage procedures. As the child grows, it is a dynamic age group, and whenever whatever comes as an harmful, we release that one only. So our concept, contrary to a lot in American Academy of Cerebral Palsy, perhaps if I am right, we don't believe in single stage multi-level surgeries. We believe in multi-level. Maybe we combine neurosurgery with a little bit of the soft tissue initially if they have contracture, and then orthopedic procedures, which comes usually after the age of 8 years, and then ablative procedures only after the age of 4 or 5 years, whether it is SDR, SMF, or botulinum. And but non-ablative procedure can be considered, but usually it is after the age of 6 or 8 years has to be considered. But yes, anytime up to this age, even after that. And therapies, orthotic continues right from the beginning to they are adult. So I extend my thanks to Neurological Society of India, and my colleague Dr. Shibu will also highlight some of the things during our discussion. Over to all of you. Thank you very much.
So let me introduce um, the next speaker, that is Dr. Lokesh Lingappa. He's currently the Clinical Director, Division of Pediatric Neurosciences, Yashoda Hospital, High Tech City, Hyderabad. He's currently President of the Association of Child Neurology India. His term is from 2026 to 28. He's the executive body member of the International Child Neurology Association. That is he'll remain in that position from 2026 to 2030. His fields of interest are critical care neurology, stroke, and preventive pediatric neurology. Awards and recognitions that he had, he's described a new mechanism for stroke in children. And currently today he'll be speaking to us on the physiology of spasticity and its medical management. Over to you, Dr. Lokesh.
Yeah, thank you for that introduction. I think Professor Purohit has covered a lot of physiology of the spasticity, so probably I'll skim through that part, and we'll focus on the medical management and other aspects, and including some of the diagnostic aspects, which when we are initially managing, we have those challenges. So we'll go through I think, physiology of spasticity very briefly, and the differentiation between what are the differences with when we see a pediatric versus adult spasticity, what are the different etiologies, and how the etiologies change our approach to management, and also what are the tools to assess spasticity which we need to use on a daily basis in the clinical setting, and what are the medications and what are the benefits or side effects of them, and role of botulinum toxin in brief we're going to talk. The term spasticity was first used by Good in 1829 when they had these drawings which were written, which you can clearly say there is evidence of spasticity here. And later on, Dr. James Lance gave the definition of spasticity in 1980, which was reported as a velocity dependent, and it is associated with increase in tonic stretch reflexes with exaggerated deep tendon reflexes, which in turn result in the hyperexcitability of the stretch reflexes. So this is one of the key component of the upper motor neuron syndrome. And I think Dr. Purohit has already shown lots of this. So on this as well, we have discussed. So we have to classify whether the spasticity is focal, that is a single muscle group or a part of body is affected, or whether it's a region is affected, like a spastic diplegia, hemiplegia, or is it generalized, which can happen with spastic quadriplegias in cystic periventricular leukomalacias and other kind of structural brain abnormalities. These things can happen. So we all know that the resting muscle tone, there is resistance to the passive stretch, which we can feel when you keep examining these infants and children. We can differentiate. So one is hypotonic, one has a normal tone, one has slight spasticity. So examining across all the different joints gives us a feel, because some children have just adductor spasticity, some children have just a spasticity in the hamstrings, where some have the spasticity in gastrocnemius and soleus, likewise. So we need to document examining each area of the baby, so that we know which part is affected and how is it affecting the development of the child, and what needs to be done to improve that. So the supraspinal control of this spasticity, you have an anti-spasticity pathway and a pathway which actually facilitates the increase in the muscle tone. So what are the anti-spasticity pathways? It's usually from the premotor cortex, where you have a cortical reticular tract, which goes to the medullary reticular formation, and then you have a dorsal reticulospinal tract, which is inhibitory to the stretch reflex circuitry, which Dr. Purohit alluded to, which is always in the excitation. So this is a antispasticity pathway. Motor cortex, once again, is the corticospinal tract is inhibitory to the stretch reflex circuitry, whereas the pontine reticular formation through the medial reticulospinal tract and the lateral vestibular nucleus through the vestibulospinal tract are facilitatory to the stretch reflex circuitry. So these causes reflex actions like when you're turning, if you're trying to lose balance, so reflexively your muscle control, muscle tone is increased on that side to maintain the balance. So these are very helpful in maintaining the balance. So among all these tracts, the muscle tone is mainly regulated by the inhibitory dorsal reticulospinal tract and the facilitatory medial reticulospinal tract. Most of them are involuntary in nature. And what are the factors contributing to spasticity? In the pediatric age group, it's usually the supraspinal influence, that is loss of inhibitory descending control from the corticospinal tract and the dorsal medullary reticulospinal tract, and with a relatively preserved pontine tracts and the vestibulospinal tract, because predominant injuries, the pathologies which cause injuries, which will come to later, are in the cortex rather than the brainstem. So that's why there is loss of inhibitory descending control from the corticospinal tract and the dorsal reticulospinal tract, which happens to start from the premotor cortex. And the spinal influence, the causes of the spinal pathologies, thankfully, are less in the pediatric age group. And there are defective sensory feedback can also cause a lot of issues like in hereditary spastic paraplegias. Once again, I'll show you with our data that these incidents are very less as compared to the static encephalopathy secondary to perinatal insults. The chronic spasticity just does not cause change in the fiber size. It also changes the histopathology of these muscle fibers. As you can see, the normal distribution of the type 1 and type 2A fibers here. And then in cerebral palsy, you can see there is a reduced number of fibers, type 1 and type 2. There is increased collagen, and also this in turn causes significant thickening of the perimysium. All these things reduces the muscle elasticity. So there are large structural abnormalities in the molecular aspect of these children within the muscle. So it can cause significant long-term structural change. So managing the spasticity very early on, a neonatal graduate, NICU graduate who had a perinatal insult has to be followed up very early, start early intervention and keep working on them so that a lot of this long-term structural changes can be reduced significantly. Another concept is hyaluronan is seen is a chief component of muscle extracellular matrix. And in a normal concentration, it functions as a lubricant. It enables sliding between the muscle fibers and bundles. But whenever there is reduced mobility, this increases. When the hyaluronan increases, there is a increased resistance to the movement. That is one of the reasons which can cause significant worsening of the spasticity. What are the differences between the pediatric adult spasticity? As you know, it's occurring in a developing brain, and motor skills are being learned still, and they have high developmental plasticity and continuous muscle and bone growth. So although the injury is static, the manifestations are dynamic in the pediatric age group as compared to adult. And the functional goals is here is to enable acquisition of new skills, whereas in adults to restore the lost functions. So what is the etiology and natural history? These actually are very important to consider when you are managing a child with spasticity, because that decides how much investigations we need to know the etiology and the long-term outcomes, whether we can make this child walk. The parent family doesn't come and ask you cure my child's spasticity. They'll come and ask, when can my child walk? I think here, if somebody can see, I had an invitation labeling me as a fellow in pediatric numerology. And this was something I felt annoyed at that point in time. And then later on, I realized every day in the clinic, we have to do this numerology. Most of the parents ask, when will my child walk? When will my child talk? And then you need to have a scientific, educated guess and counsel the families. So these things are important because whatever the interventions you are trying to do is trying to give them, whether it's a ambulation is possible or wheelchair ambulation is required in some children who are more severe, and what timelines we are looking at, all those things we need to counsel these families. The common etiologies are for acquired spasticity, as it forms the most common group of children who would require this intervention: perinatal asphyxia, intracranial hemorrhages, sometimes head trauma, CNS infections, and strokes, and occasionally metabolic and toxic encephalopathies, periventricular leukomalacias in the extremely premature. These are the common etiologies which contribute to the spasticity plus dystonia in pediatric age group, including the bilirubin-induced neurological dysfunction. So if you are looking at the inherited causes, there are a huge group of conditions which will not go into the detail. So you can have a degenerative causes, metabolic causes, and then myelopathies as well, contributing to the spasticity, which are far less common. We had done a study in our center where we looked at the spastic diplegia in 6 to 18 years of age, and what we found was after of the 2006 children which we were able to as a denominator with spastic diplegia, 141 children, that is 50%, 15% had non-acquired etiology of spastic diplegia, which means that they had likely a genetic underlying etiology. So these were the various genes which we could detect in this group of children. I'm not going to the detail again. Once again, spastic diplegia, spastic paraplegia genes constituted around 25% of this genetic spastic diplegias. And these are the various MRIs you can find in them. One of the important thing here is when we are trying to intervene, we need to know what is the natural course of the disease. Whether it is a slowly progressive, the gene causes a slowly progressive disease, or they have a static course. So almost 79% of them had a slowly progressive course, which means that you do an intervention which is surgical or otherwise, and then despite that the disease process might progress and whatever the acquired milestone might be lost. So the counseling on these aspects are important when we are doing a intervention in this group of children. For that, understanding the etiology becomes extremely important. I think this is a summary of it. I will not go into details again. So another small group of children we looked at was spastic diplegia, where it was secondary to a perinatal cervical cord injury, which we presented in recent International Child Neurology meeting. So of the 2006 children who had spastic diplegia, 84% had acquired perinatal injuries. 5, that is 0.29%, had a perinatal cervical cord injury, and all of them had a breech presentation. And whether even they were delivered with a cesarean section during breech presentation, still some of them ended having cervical cord injury, like you can see here the narrowing and the gliosis which is seen. So here the reason why I'm bringing up this is because these children undergo lots of extensive investigations, especially in the era of genetics and metabolic testings which are available. And then the risk for next pregnancy is explained, and parents get very anxious to have another child. So once you diagnose it's a non-recurrent pathology and we know it's a spinal cord pathology, cerebrally they will be fine. So it will give a clear answer to the family, and the management will be focused on the rehabilitation part of it. So it's important to remember this as a differential diagnosis of spastic diplegia. So if you don't treat the spasticity, it can give rise to contracture, deformity, and displacement and dislocations in severe spastic diplegias and quadriplegias. That's why surveillance becomes extremely important. They can have scoliosis. Pain and sleep disturbances can be there if there is a joint dislocations especially, and functional impairment in the form of loss of sitting balance, and they have to have more energy expenditure to walk, and also the psychosocial impacts and impaired quality of life. So in clinical setting, we always try to use some of these scales. Modified Ashworth scale is most used around the world, and TADU scale as well. So we document all these things in the clinical notes with or without intervention, what is the differences and which muscle group is getting better. So each individual muscle group will be charted based on these scales. These are various other tools which are used in research setting. So the goals of treatment has to be clearly laid out. So whether it's to reduce the pain or spasm, improve range of movement, and improving walking distance or stamina, ease of transfers or standing, ease of dressing and self-care, and tolerance of orthotics, like if you're putting a AFOs, whether they're able to, if it is very tight ankle, you are putting AFO in the night for long hours, it can cause significant pain and stress, pressure ulcers as well. So you need to be careful. So all of these things have to be managed individually. Each child has a unique requirement. So I think with this we have gone through already. So these are the pyramid. Physiotherapy and rehabilitation is for all these children who require intervention. Orthotics and assistive devices in children where it is required. Oral medications, will come to that in a minute. And botulinum toxin in a few children where there is a focal spasticity, that will be beneficial. And other things have been already discussed and once again will be discussed. So coming quickly to the oral medications, these are the few oral medications we generally tend to use, but we'll discuss about what we do. The medications which are generally used are baclofen, which is a GABA B agonist, and it's usually pre and post synaptic inhibition at spinal cord. That's why it works well in the spinal spasticity, but does not do the same work when it is a cerebral spasticity. And clonidine is used in some children, tizanidine, diazepam, and clonazepam. So baclofen has been tried in generalized spasticity. Spinal spasticity is best outcome, and even in multiple sclerosis, it's spinal cord involvement. It is absorbed well orally after enteral administration, but has a low lipid solubility, and that's why it doesn't cross the blood-brain barrier very well. So as a result, if you have to get a reduction in spasticity, you might have to use higher dosage. When you use the higher dosage, obviously the side effects come into fore. What are the major side effects we see? Sedation, drowsiness, and respiratory and cardiovascular depression can be there. Abrupt withdrawal can cause rebound spasticity, headaches, hallucinations, and infrequently you can have other manifestations. But oral baclofen pump, you can use it at a low dosage and it can help to reduce the spasticity. But oral baclofen pump, when you use it, these children, most of them have a weakness in the trunk as well. So when you are having weakness in the trunk and you are giving a muscle medication which reduces the tone, you are going to probably lose that tone as well. So that's why we are very, very cautious in using baclofen. We rarely use actually baclofen in the cerebral spasticity. Tizanidine is another drug. I'm not sure how many of you actually use in the clinical practice, but it once again has a significant long-term side effect in the form of the children become dependent. Weaning from this medication is very difficult, and they have significant loss of sleep when you are trying to wean off this medication once you have used it for a year or so. So somnolescence is the most common adverse effect, and xerostomia is the second most frequent complaint, what we have seen with tizanidine. So we don't use it regularly once again. Diazepam, unlike baclofen, diazepam potentiates GABA A throughout the entire neuroaxis. And so that is why it has been earlier used significantly. But now, once again, we don't use it because a lot of these children have, once again, sedation, amnesia, significant muscle reduction leading to loss of truncal tone. So current practice is the best guideline grade. This has some guideline because this has been used for a very long period of time. But it is also discouraged because of the long-term side effect, which is known. So it can be used in acute spasm crisis, nocturnal spasm control in spinal cord injury, and brief procedural relaxation, but not as a long-term antispasticity medication. Trihexyphenidyl, is there a role in spasticity? If there is a combined dystonia and spasticity, there might be a role, but only if it is spasticity, there is no role for muscarinic blockage. and has no FDA approval for this recommendation. And this is the American Academy of Neurology recommendation for various medications. For diazepam, there is level B evidence for short-term antispasticity medication, not on long-term. Baclofen, there is a conflicting class 2 evidence regarding the effectiveness, but in fact, insufficient evidence to support or refuse the use of oral baclofen for the treatment of spasticity. And tizanidine, possibly effective, but there are not many studies, only level C recommendation. We don't use it regularly because of the long-term side effect of the medication. Botulinum toxin, I think I'll quickly go through. How much time do I have? Okay, I think I can. So we need to see which muscle. Generally, we start using the botulinum toxin when they are around 2 years of age. It works well until they are 6 years of age, and beyond that, the muscle tone is so increased, and the reversibility factor keeps reducing. So we start reducing the usage of Botox after they are 6-7 years of age, and the MAS factor 2 to 3 score is somewhere where the botulinum toxin works very well. If you have going more towards contracture, that is 4, then it obviously is not going to help. The best responses is between 2 and maybe early part of 3. You get a best response to the botulinum toxin. And as we said, usually given after 2 years, but in some of them where there is spasticity starts very early and severe, we give even at 1.5 years of age. It is very safe, done on an outpatient basis, and usual maximum dosage is per site is around 50 units. Pediatric age group use a smaller dosage as compared to adult, and maximum total dosage somewhere around 300 units is maximum what you give in the pediatric age group. And one of our student who did a research on this one showed that the children with spastic diplegia had the best response to botulinum toxin as compared to other like hemiplegia, and the adductors and gastrocnemius had a very good response to botulinum toxin, including improvement in the functional effect. So somebody was not able to sit after the adductor injection, started sitting, and somebody who was not able to, was walking with support, was able to walk without support. So these transitions happened more in children after the botulinum toxin. So functional improvement was also seen, as I discussed, from level 3 to level 2 after the botulinum toxin, which was a meaningful gain in the gross motor function, which was noted. And what predicted the better outcome to the botulinum toxin? Children without comorbid epilepsy demonstrated significantly better outcomes to botulinum toxin, and the spastic diplegia, cerebral palsy subtypes had a better response to the intervention. I think I'll stop here. So it is a multidisciplinary management, and once we know that this medical or the botulinum toxin, physical therapy, orthotics are not helping, then we involve our colleagues, orthopedicians and the neurosurgeons to see what else can be done to help the child ambulate. Thank you.
Thank you, Dr. Lingappa, for a wonderful talk. Our next speaker is Dr. Benedetta Petroni. She's qualified from...
Sir, next speaker is Dr. Lokesh. Dr. Benedetta will speak after this. Dr. Pawan.
Next speaker is Dr. Pawan. Okay. Dr. Pawan completed his MBBS and MS in orthopedics from Osmania Medical College, Hyderabad. He finished his post-graduation in 2007. He completed a specialized foot and ankle fellowship in Baroda in 2017. He has a keen focus and expertise to correct flat foot deformities. He's a foot surgeon. He has innovative practice in biomechanical interventions. He's known for an innovative approach to orthopedics, pioneering many non-surgical management of foot and knee pain. He specializes in biomechanical correction of foot using customized insoles. He has a collaborative practice in cerebral palsy. For the last 2 years, he has been working in close collaboration with Dr. Purohit. He's into treating complex foot issues in children with cerebral palsy. Um, he is renowned for his deep patience and compassion and in the welfare of children. He'll be speaking on the orthopedic management of spasticity. Dr. Pawan, please take it.
Yeah, good evening all. Can you all see my screen?
Yes, sir.
Yes, sir.
So I am the orthopedic surgeon in the group. My association with Dr. Purohit started 2 years back when I started dealing with his patients who had grown up with foot and ankle problems. So now today my talk is spasticity, our ortho-neuro approach, how we do it, ortho-neuro combined approach. So first of all, I'll thank NSI and all people here, Dr. Purohit, Dr. Sachin, and Dr. Matthew for inviting me here. So we all know that problem is central cerebral palsy, but we are looking for peripheral solutions because the problems are peripheral. And what happens? What is the natural history? When we have the child, early childhood, they have only spasticity. But in the middle age, 5 to 10 years, they have spasticity plus muscle shortening. But as they grow older, we have spasticity, muscle shortening, bone, joint, torsional deformities. So we need to do a combined approach for neurological and orthopedic interventions. So what we have with the ortho-neuro approach in neurosurgery, two methods, selective dorsal rhizotomy and selective motor fasciculotomy. In orthopedic surgery, we have the muscle lengthening, tendon plications, tendon transfers, arthrodesis, fascia releases. So all Dr. Purohit sir has spoken about rhizotomy and selective motor fasciculotomy, so I'm not going to speak much. As you all know, rhizotomy involves opening the dorsal nerve roots and cutting the sensory nerve roots. It has got some advantages of low risk and one-time procedure. Selective motor fasciculotomy also involves cutting the nerves, but at motor nerves. And it's also one-time procedure, less cost involved, and free of maintenance. So which surgery? If we have only spasticity, we can go for rhizotomy or fasciculotomy. But if we have muscle contracture, muscle weakness, bony torsional, arthritis, or tendon weakness, we have to go for the orthopedic procedures. So now I will show you some case examples, like this child having spastic right hand, difficulty in opening the hand. These children have difficulty in cutting the nails because the moment the caretaker is trying to open the hand, they become more spastic. Now we have done so this case is only spastic case. It's not a contracture case. So we have done a selective motor fasciculotomy of the median nerve. And now you can see the child, the wrist is getting into extension, holding object, child is comfortable, hand is opening, thumb is also opening. Another case. In this case, the child is having spasticity plus contracture. So if you see, there's a contracture of the pronator group of muscles in the forearm, and the child is not able to do supination of the forearm. So in such conditions, we do median nerve selective motor fasciculotomy plus an orthopedic procedure called the flexor pronator release. So the origin of the flexor pronator group of muscles from the medial epicondyle of the humerus is released. And you can see the pre-op and the post-op, the child is having supination of the forearm, the hand is opening, the fingers are opening, the wrist is getting extended. To hold an object, the child needs to extend the wrist. So how we do these procedures? Because we are all surgeons, we need to see some surgeries. So this is exposure of the musculocutaneous nerve in the upper arm and dissect the branches, the fascicles which go to the biceps and the brachialis muscles. And each nerve will have about 4 or 5 fascicles entering the muscles. And then we do a neurostimulation with a nerve stimulator and see the hyperactive fascicles which are giving abnormal contraction. You can see that contraction, and then we ablate the nerve fascicles which are hyperactive. Similarly, I can show you a median nerve example, which is in the elbow. The nerve is emerging between the two heads of the pronator teres muscle. And then similarly, we do the dissection, stimulation, and ablation. So we slowly dissect the nerve into the fascicles which are going into the pronator muscles. And then after stimulation, about 25 to 75% of the fascicles, we do a neuroablation. To prevent the recurrence of the neuroablation, we cauterize the nerve and put a staple. This is how we are stimulating the long flexors of the medial nerve. And this is the cauterization of the nerve ends before we cut it. So another example, now a child left hemiplegic, if you see walking, he's got a spastic tendoachilles and he's got a hamstring contracture. So we can do an ortho-neuro combined approach where we do a tibial nerve selective motor fasciculotomy and hamstring lengthening. Now you can see the child post-op 1 year walking foot plantigrade on the ground, and you can see the scar of the tibial nerve SMF and the hamstring lengthening. So this is how the tibial nerve looks in the popliteal fossa, and this is how we stimulate and then see all the movements, the plantar flexion, inversion, eversion, toe flexion, and depending on which fascicles we need to neuroablate, we do the dissection. Another case, here we see there's a tight TA, tendoachilles contracture, plus he's got a spasticity in the knee flexors. So in this procedure we have done a sciatic nerve selective motor fasciculotomy, and we have done a tendoachilles lengthening. Of course, this child hemiplegic, so there is some limb length discrepancy which can be corrected with a footwear elevation. So again, we have combined an ortho-neuro procedure. As an example of how we do the sciatic nerve SMF, this is the marking just below the gluteal fold. Again, exposure. And on the upper side, you can see all the fascicles which are going into the medial hamstrings. And on the lower part, you can see the main sciatic nerve and the common peroneal nerve. So this is how the exposure is set. So that is very close to the myoneural junction. If you see, that is the place we get the maximum. We have to go up to the myoneural junction. And then again, do a stimulation with a nerve stimulator and see the hyperactive fascicles. You can see the medial hamstrings getting contracted. And again, we do the neuroablation of the hyperactive fascicles. So another case, now this child is a crouch patient. If you see, he's a late presenter, spastic diplegic. If you see, so much of knee flexion deformity, planovalgus foot, because of the contraction of the hamstrings. The patellar tendon is elongated and he's got a patella alta. So now what? So we have a spasticity. Solution is dorsal rhizotomy, hamstring contracture. So we have done a muscle lengthening, patella alta, where the patella is high riding and the extensor lag is there. So we do a patellar tendon plication. He's got a planovalgus foot, which will be addressed in the next sitting. So after doing the rhizotomy in the prone position, we have turned the patient supine, and this is how we have done the patellar tendon plication. We have raised a flap and then we have imbricated it, and then you can see the shortening we can get. So this is the pre-op and the post-op X-ray. We can see high riding patella, and in the post-op we can see how we have got down the patella. This is for a skeletally immature patient. If it is a skeletally mature patient, we do the tibial tuberosity advancement. Another child who had a dorsal rhizotomy in childhood has come later with a planovalgus foot. If you see, he is having severe planovalgus, painful, non-braceable. The left side is a pre-op image, no stability, very difficult in walking. And then after about 2 months post-op, he's able to walk. Pain is not there. Sorry. So you can see he can walk properly. Of course, the left foot is slightly invalgus, but it is a braceable and a non-painful foot. Another child, right foot deformity, secondary to myelomeningocele in childhood. If you see, the foot is totally deformed. The tibialis anterior muscle is contracted, non-healing ulcer because the child is walking on the lateral border of the foot. So in this case, we have done a orthopedic osteotomy, bony osteotomy, where we have removed the piece of the bone on the lateral side. Similarly, tibialis anterior, which was contracted, we have transferred it to the lateral side to get a valgus. This is the post-op. Now the child is having a braceable plantigrade foot. Sometimes our orthoneuro approach we do for palliative treatment for spasticity with contracture. This is a child, global brain damage. See how the physiotherapist is doing physiotherapy, not knowing that she may cause a fracture. Very painful. The child is crying. The sister is trying to console, but the child doesn't know. The physiotherapist doesn't know what is happening. He's still doing it. So now we have done a combined orthoneuro where we have done the selective motor fasciculotomy of the sciatic nerve, obturator nerve, and same sitting we have done the hamstring lengthening. So all our procedures are tailored according to the child, whatever problems they are facing. So now the child is a little comfortable. He can be turned around in bed. The transfer can be easy and very comfortable. You can actually is comfortable. Another case of scissoring where a child is having, she's a girl 15, 16 years having scissoring because of adductor spasticity. She's a CP child with a mild affection of the adductor muscle. And when she walks, both the, if you see the walking, see, this is extensor spasticity. We don't touch the extensor spasticity because it is helpful for walking. And when she walks, both the thighs are touching each other. So there's a problem for her to walk. Post-op, after doing the selective motor fasciculotomy of the obturator nerve, both the thighs can be abducted easily. So this is how we do the obturator nerve selective motor fasciculotomy. Again stimulating.
Yes,
And again
आ रहा है ना छोटा छोटा सा.
ablating it. So conclusion in our experience, combined orthoneuro procedure is a great tool for treating children with spasticity and orthopedic problems. Thank you very much.
Thank you, Dr. Pavan, for a wonderful talk. Our next speaker is Dr. Benedetta Petroni. She has qualified from Catholic University, Rome, Italy in 2002. She has completed a basic surgical and neurosurgical training from Rome. She has undergone advanced pediatric neurosurgical training from UK. She has fellowships in pediatric neurosurgery at Birmingham Children's Hospital, Great Ormond Street Hospital, London. Currently, she is the consultant pediatric neurosurgeon at Alderhay Children's Hospital, and she's director of the division of surgery Alderhay, and she's associate professor in the University of Liverpool. Her fields of interest are hydrocephalus shunts and basic and complex endoscopy, Chiari malformation, spinal dysraphisms, neuro-oncology in pediatric patients. She has a lot of experience in baclofen pump, selective dorsal rhizotomy, and peripheral neurectomy. She also has interest in neurosurgery in prematurity. She has been an extensive educator for people who are interested in learning the field. Thank you so much, Madam, for joining us today. And she will be speaking about neurosurgical management of spasticity.
Thank you so much, and thank you for the invite. I'll start sharing. Let me know if, can you see it?
Yes, yes, ma'am.
Okay, and also let's make it bigger. Yeah, can you see it properly? Yeah.
Yes, ma'am.
Okay, thank you. So whilst I was listening to your interesting presentation, I was sort of hiding and deleting some slides to avoid duplications and mentioning things too many times. So I would just go back to the concept of a step ladder approach or a pyramid approach, which really is a bit everywhere. It's is the classic approach, in particularly from a medical point of view. But overall, I think over the years we have sort of moved around looking at being more patient-centered in terms of considering all the options even at a very early stage of treatment and diagnosis and diagnostic options. In terms of spasticity, as has been mentioned a couple of times already, there are advantages at times in actually having spasticity and maintaining a level of spasticity that maintains the muscle tone, that could support the circulatory function, and we do know it does have a prevention in the formation of DVT, and in some children, spasticity does assist in activities of daily living, in particular around transfers, in particular around the GMFCS level 3. However, not all the spasticity is good and should be kept as it is, because it does interfere or could interfere with mobility, with the range of motion, with activities, with mobility. It's painful very often, and sleep is very disturbed, and overall looking after children with spasticity, in particular in the severe cases, does affect carers significantly. Therefore, we really need to think, as I said, at a patient-centered approach and really understand how we can optimize their life and how we can actually achieve the best outcome overall. So it's a question of balancing what we have in front of us and really tailoring our approach and the options that we have available. Overall, why would we treat spasticity? I tend to say I'm a neurosurgeon treating spasticity. I don't treat the cosmesis of the gait, but I work very closely with the orthopedic surgery team in order, as I said, to optimize all the aspects of the movement disorder. And overall, the main reason overall is to decrease the spasticity when we know it does interfere. Not having spasticity or having it considerably less does improve the functional ability, can improve the independence, can treat the pain, and in many cases completely they can become completely pain-free. In children who still haven't developed contractures, can prevent the development of contracture or can decrease it for sure. And in the patients that are not walking, there is definitely an advantage in facilitating the ease of care and improving the quality of life for them and the carers as well. So from a surgical and non-surgical point of view, this is the classic treatment modalities algorithm based on a GMFCS level. This has been discussed in the previous one of the previous talks. So we do know we do have several options that are not all surgical with Botox injections and medications. Therapy itself, in terms of physiotherapy itself, at times is enough for some children, and then escalating to the surgical treatments, in particular baclofen pump and selective dorsal rhizotomy. Rehabilitation therapy is fundamental in any of the options that we would consider. I don't do for rhizotomy if I know that there is difficulty in accessing a consistent physiotherapy service, or if the compliance has been poor in the past. As during these treatments, we know physiotherapy support is really should not even be considered. But that also applies to botulinum toxin, and in my opinion, does apply to medications as well. The optimization of the outcome is a joint effort. We've gone through the oral medications and the Botox already. And as we said, the soft tissue procedures, it's very interesting to see how the neurosurgical part and the orthopedic part jointly work very well. I operate with my colleague orthopedic surgeons very often. I do roughly the same what you were before. It was mentioned before about adding neurectomy with soft tissue surgery, and the results are excellent. So in terms of concentrating on the neurosurgery treatment solely, I would consider baclofen pump and selective dorsal rhizotomy primarily. Neurectomy is it's less often done because the selection of the patients is actually more well, it's more rare to have patients that would benefit from a neurectomy, although there are plenty, and it has been discussed at the previous talk. So intrathecal baclofen, the actual dose of the intrathecal is not related necessarily to age or weight, although we do consider weight a factor, and based on the literature is sort of arbitrary. Historically, at least in the UK, there was a cutoff of not inserting a pump in children whose weight is less than 25 kilos. But there has been several publications recently where actually baclofen pump has been done in much smaller and lighter children. I've done it myself, so I wouldn't consider this 25 kilos, and to be honest, I don't know what in your units your threshold is, but I can tell you, I would say roughly in Europe that would be considered the right thing to do, but in many cases, I think again we need to think a bit outside the box and really understand what the situation is in front of us. As you know, baclofen is delivered continuously. It is a programmable pump, and baclofen is it's going directly in the CSF in the subarachnoid space, and the rate of infusion can be varied during the day. There is the Flex software, and so if the patients will have more spasticity in the morning, as often is, a boost can be done and automatically given by the pump with the programmer. So it works well. Again, in Europe and in America, the only available pump at the moment is the Synchromed from Medtronic. And the reports in terms of having software issues or programming issues are extremely rare. So if there is a problem, the problem is usually not the hardware or the software, is mechanical. Again, in literature, there are different options, and also there are units around the world that would implant a pump without doing a screening test, or what we call a test dose, which is basically a trial. The reason to do a trial are probably dual. So one is to make sure that there are no immediate side effects to baclofen, even if these patients would be on oral baclofen or would have been on oral baclofen in the past. Intrathecal is a different composition, therefore trialing that there is no massive side effect, in particular around respiratory function, I think is indicated. But again, there are several reports of test dose not being done. And if we were to do a test dose, then there are the two options: either do it as a shot, so as a bolus test with one injection through a lumbar puncture, and physiotherapy assessment and proxy assessments done 2-3 hours later. Or it's an infusion test, so a small lumbar drain would then inserted left in situ, and then baclofen would then be infused by an external pump. I personally do infusion because it gives more time for the physiotherapy assessments to happen. You can do more than one. If you do a baclofen in walking patients, you could do a gait analysis. You can take the patient to gait analysis lab whilst the infusion is ongoing. And also overall, it gives also the family a longer time to really understand if they see a good effect, if that is enough for them. So overall, I have switched from bolus test to infusion test over 10 years ago now, and I kept going like this. This is roughly what we do in terms of escalation, in terms of dose. We will always start on a very low dose of intrathecal baclofen, and then if there is no significant effect or we want to leave it for longer, we can also increase during the same infusion test. The plant is in the subcutaneous subfacial pocket, usually put in the anterior abdominal wall. And as you know, even the 20 ml reservoir, there are the two options, 20 ml and 40 ml. The pump is quite bulky, so the anterior abdominal wall is a better host, and it could be more or less superficial in terms of subfacial or subcutaneous. It's a surgeon's choice, really. Personally, I do subcutaneous. There is a slightly increased risk of seroma in subfacial implant, but again, it is a surgeon's choice. And the catheter is threaded, the subarachnoid space, usually, of course, below the conus, and then advanced superiorly. Some people check with the X-ray to check the length of the catheter, others don't. Again, surgeon's choice. And it's fixed on the fascia at the back. Again, some people don't fix it, but these are all technical aspects that you might change your practice over the years based on potentially on the complications you have, as always we do in surgery. Again, it's another balanced situation. What are the pros of choosing a baclofen pump as an option? It's adjustable, it's reversible. So if you put a pump on, actually there are problems with it, or the results are not as good as the pump, can always be taken out. Surgery is, as always, very delicate with everything we do, but it's not particularly invasive. And also the reduction in spasticity can persist for years. It does have an effect on upper and lower limbs, and it works well with cerebral and also spinal origin spasticity. And it works well on dystonia as well. So mixed pattern, spastic dystonic patients, GMFCS5 are the typical and best candidates for a pump. On the other hand, though, it is an implant, and if there are problems with the implants, as for any implant, it's trouble, particularly from an infection point of view. Some of these children would sometimes have a shunt as well, so pump infection would then sometimes means a shunt infection as well. So there are considerations to be made. It's not a one-off procedure. In particularly the first 6 to 12 months, it's demanding because the patient will need to come to you several times, or the specialist nurse, for reprogramming, for the refills, and also the refills are always a necessity. And of course, the higher the dose, the more often the refill. So you need to make sure that there is that engagement from the family when the pump is inserted. As I said, there is risk of infection, risk of mechanical complications, and also there is a specific risk, which is the risk of withdrawal. So in case of a mechanical complication and the pump or it's a blockage or a kink, then the withdrawal effects are potentially life-threatening. So in any institution, there will be a protocol, a guideline, which is written by the neurology team that would then have the plan in case of withdrawal, which would be around oral baclofen and diazepam. When this happens, and luckily that doesn't happen often at all, but the few times that would happen is a PICU admission. So there will be an intensive care treatment around the patients to avoid the most terrible complications in terms of withdrawal symptoms. So again, when choosing the pump, even if you have the perfect patient in front of you, we always need to think: can they actually do it, and is it safe to do it within the specific circumstances of the patients? Mechanical complications are rare, however, they do happen. Also, because these are complex patients overall, a lot of these patients would have a PEG or a trachea, and they would have been hospitalized several times before. Sometimes they're colonized with Pseudomonas or MRSA or MSSA. So there are comorbidities that we also need to consider in terms of healing as well. Cystic collections around the pump or the entry point of the catheter in the subarachnoid spaces are well reported. There are always problems, as I said, with the wound in terms of healing. Disconnection, however, the disconnection, I think the incidence was reported higher in the past. Few years ago, Medtronic produced a new catheter called Ascenda, which has an anti-kink technology and a new connection device. And I haven't had absolutely any problem with any pump or catheter since this new catheter came on the market. And leakage, however, in particularly at the catheter insertion side at the back, can happen, or pseudomeningocele, and it is very important to act on it straight away, as again that would be a cause for withdrawal or infection. There are cases reported of microfracture of the pump catheter. They usually happen at the time of insertion, but they can give low pressure headaches, and again, it's very important to diagnose this promptly. If there is a suspect of it, you can do access test to the pump, inject some contrast, and see if there is a leakage of baclofen, a leakage of the dye to the catheter. So you always need to be very proactive and as in order to diagnose as promptly as possible. This is now a 20-year-old paper, but there isn't much else since about complications in baclofen pump. And you can see that actually the complications are higher in pediatric rather than in adults, as expected. And so even more care needs to be applied to the pediatric patients. Again, there are a lot of different habits in terms of assess malfunction. In a lot of units, there are a lot of CTs and X-rays done. I go straight to the dye study, so you know where you are, and if the dye is going straight in the subarachnoid, there is a blush, then you're happy with the hardware of the pump. And I'm always quite, I always feel that a plain X-ray could be misleading, and you can have false negative and false positive. Therefore, I think the dye study is the most complete type of assessment. I'm always mindful that if there is a blockage, that could be a symptom of infection. It could be a low-grade infection. So again, it's important to then have this diagnosis done as soon as possible. And also, it's not uncommon to have a granuloma formation around the catheter. So although these things are rare, in a unit where a lot of baclofen pumps are done, these things do happen, and it's important to have a protocol in your mind, really. I'll just skip this. If we move on to the SDR, being mentioned few aspects already in some talks. We know the dorsal roots are irreversibly cut, so very different from the reversible aspects of the pump. Two primary goals. It's not all about mobility. It's not all about gait. Actually, for me, the primary goal is to overall facilitate patient care and improve quality of life, and of course, improve the function of walking. SDR is not new. It was done for several years in Cape Town, in particular with Peacock. But before that, there were several different versions with several different techniques. Regardless of the technique used, we do know, and the first talk has touched on this already, sectioning the afferent nerves would then stop the arc feedback and reduce the spasticity of the lower limbs. But going back to the technique, we are surgeons. So what is it that we do? How we do it? Different schools, let's say. So Peacock School has then evolved in the Park School. The principle is the same, really. It depends how big your incision is and how big your laminotomy or laminectomy is. And as I said, it is relevant to discuss what the morbidity and of course the invasiveness of the different techniques is. But one level laminotomy or laminectomy at L1, L2 is enough to access the entire conus and have your sectioning done. There are several variations of this technique, but as I said, the important thing is to have the correct access, enough space, and enough visual of the conus and the coda equina. Personally, I do 2/3 of L1. I tend to keep the ligaments between T12 and L1 to not destabilize the spine and reduce the complications that go with it. But as I said, it is sort of, it's very relevant, but it's sort of irrelevant as long as it's done properly. The question is neurophysiology versus non-neurophysiology. I don't think that there is a controversy here anymore. SDR is to be done with intraoperative neurophysiology. The techniques around intraoperative neurophysiology are well reported, but there is actually surprisingly no agreed single protocol that is universally accepted in how to monitor an SDR or how to be as selective as required in a selected dorsal rhizotomy. This is what I follow. It is from Parks and it's from Park, and it is the response to a tetanic stimulation. So the higher the response, it is a grading between 1 and 4. Grade 3 and 4 are the ones most involved in spasticity, therefore to be less selective. What are the pro of using neurophysiology? Sorry, it's my dog. Sorry. Sorry, close the door. First of all, it's the confirmation of the dorsal nature of the root. So it's, of course, we can't possibly cut the motor root in a selected dorsal rhizotomy. So confirmation that we are right, that it's a sensory root. Confirmation of the level. In some units that doesn't happen. I think it's very important to make sure that we cut all the nerves that we are supposed to, and also having the direct tetanic stimulation is a good guidance to maximize the spasticity reduction. But as I said, there are no validated criteria. Nobody has written about correlating with a good outcome. And again, as for everything, we need to know what we're doing. There is an effect of anesthesia on responses intraoperatively. it's not uncommon that we need to switch from complete TIVA to gas in order to have a different response to the threshold. So again, it does require a good experience, and it does require a lot of knowledge and good communication with the neurophysiologist. Overall, a lot of centers use it. I don't know if you remember, but over 20 years ago now, the Vancouver team published that there was no difference between their series between neurophysiology and non-neurophysiology. And then 10 years later, a following publication showed that actually the outcomes were much better when using neurophysiology. And in most units around the world, neurophysiology is used routinely. Patient selection, I think this is a bit more controversial. There are a lot of publications. I've only picked this because, without going into many details, but these are 3 publications, and 1 is mine. And there are differences in patient selections. This is the multi-center perspective study that we did in the UK like 2-3 years ago, where actually the selection criteria was different than what our system was expecting. Why is the patient selection in SDR so variable? Well, it hasn't been generally validated. There are mostly very limited single center or multi-center, but still limited series. The clinical, the scientific evidence is only partial. There is more clinical rational, and I am supportive of strict selection criteria as they can enhance the outcome, but they can also limit the scope of practice. And the main repercussion is that they can restrict the evidence base for those that are not included in the selection criteria. So based on the majority of old literature, the GMFCS 2 and 3 are the ideal candidate, in my opinion, and in my series, and I'll show you, level 1 and 4 have very good potential, that they respond very well to SDR. And I would actually say that GMFCS 3 are the most difficult because they can come with a very wide range of performances. The stronger the better, well, of course. However, they're not all this lucky, and also severe spasticity can disguise the true extent of weakness, and actually sometimes it can underestimate the true weakness. So again, some children will be penalized and not have an SDR because of it. Ideally, no contracture or minimal contractures, but a lot of patients, particularly level 3, would have contractures. And they have to be cognitively good enough to follow a rehabilitation program. And more importantly, the expectations need to be set right, in particular with the family. This is a paper now from 2013, but it is one of the main papers that the NHS in England picked what selection criteria to use, so the ones I showed you before. But interestingly, this paper showed that vast majority of the patients included were actually level 4. So I feel that in the process of selecting the selection criteria, some evidence has been left behind. I started my service in 2012. We were commissioned, so only 5 units in the UK can do, in England can do SDRs. We've done a lot of work, and actually only last month we published our 10 years result, and we get referrals, however, from the entire UK, and provide the service for Northern Ireland as well. I'm showing you this because, of course, compared to India, the numbers are extremely low. But for the size of the UK, numbers are quite good. We do run a national audit, and there are no more than I think last we had probably 100 and 120 SDRs done every year, and that's why it has been commissioned in only a few centers. This is our pathway. It's quite complex, but actually it's not that complex. In summary, all the patients referred would have a full physiotherapy assessment before seeing myself as a neurosurgeon. They're seen by a clinical specialist physiotherapist first as a sort of triage. Each assessment would be 2-3 hours, and then based on that, then we decide which is the best clinic to have the patients into, which could be with the neurologist, which could be with myself if it has the RO pump, and then we also have a DBS service, so they will go into that pathway if it's more appropriate. And then the walk-in patients would have a gait analysis done as well. A physiotherapy assessment with an updated GMFM would be done the week before the surgery. And then it's the surgery. Our surgical pathway is 3 weeks, with 1 week as an inpatient and 2 weeks in the Ronald McDonald House and with twice daily physiotherapy. That is in total for 3 weeks. And then they're referred back to the community physiotherapy. And then we do post-operative assessments, 3, 6, 12 months, then 2 years, 5 years, and 10 years. And we only repeat the gait analysis at 12 months, 2 years, and 5 years. And we work very closely with the orthopedic team in case, of course, there will be orthopedic problems either pre-op or post-op. Considering over 300 patients, the age is around 7 years of age, and which fits with the commissioning criteria, which are between 3 and 10. However, out of commissioning, I've also done some teenagers and also some high-level GMFCS. So this is what it looks like. So very few 1, very few 5, as you can imagine, and I'll tell you why I've done them. Vast majority is 2, 3, and 4. So I've done only few 1, and they were children who were very driven with of course all cerebral palsy, but very, as you can imagine, very independent. However, there were children who wanted and demanded a future as professional sport athletes. So that is the reason why it was done, and with very good results. And 5 are the children that I felt that the risks for an implant of a baclofen pump would have been too high. And so because the main pattern, although not clean spastic cerebral spastic diplegia, would have benefited from less spasticity in the lower limbs. And so those are the ones done as 5. Now, if you see the mass, I mean, we do know SDR works, so spasticity is almost non-existent compared to baseline. There is only one exception where we still found some significant spasticity post-op. But for the rest of 3, it's 1 out of 3 over 300 patients. The same applies to GMFCS level 4, because there were some reports that would say, the more the spasticity, the less effective the SDR is. Not true in my series. The spasticity goes, and I'll tell you, it doesn't come back at least at 10 years. This is the GMFM stratified by GMFCS, so you can see that the mobility does increase in all GMFCS, including the 4. There is a subcategory of GMFCS level 4 where actually they've got more potentials than what we think, and I never give the expectation that they will get out of their wheelchair, absolutely, but in terms of overall independence, that they definitely improve. If anything, is that they can stand and brush their teeth. So that's the kind of independence they're looking for anyway. But in terms of GMFM, it does improve. This is at 2 years. This is quality of life. This is a proxy score, so by the parents, and you can see how it keeps improving. And this is by GEM. I only picked the 3 and 4. You can see in terms of quality of life by the carriers how much the quality of life improves also in GMFCS level 4. This is 6 minutes walking test, of course, for the ones who can do it, and it is statistically significant that goes up. And I also put this because, again, there are a lot of reports in the past that would say, oh, never ever do SDR in a patient with dystonia. Now, as it happens, I have done some patients with dystonia. I never, of course, ever do it if the dystonia is in the lower limbs, measurable in the lower limbs. I only do it if there is a predominant pattern of significant spasticity of the lower limbs and some dystonic movements in the upper limbs. And the dystonia in the upper limbs doesn't go any worse. We've actually published this last year. So a lot of options, and can we use an algorithm to really understand what the best option we have to give? Now, can we use it? Yes, of course we can. Does it cover everything? No, but at least we can simplify, if possible, what is reversible, what is permanent solution, and what is for focal and what is for generalized spasticity. I am supportive of doing trials before, so look before you buy. So I do motor block trial for neurectomy as well. We do an injection around the posterior nerve, tibial nerve, with lidocaine under ultrasounds, and do the assessment afterwards, and that counts as a trial for neurectomy. And as I said, I do baclofen test dose. I do baclofen test dose also sometimes to select patients for SDR, in particular for level 3. Again, the ones that is very difficult to understand if they're strong enough. So we do baclofen tests so we can actually measure the muscle recruitment and then decide if there would be candidate for an SDR or not. The correct indication is what it matters in SDR, and we really need to make sure that we clarify the expectations with the family, and also I always set with them 3 goals for the surgery, and on a vast scale I consider the most important outcome measure that we consider. So what does it really matter? How do we measure success of an SDR? Because the spasticity goes, we know, but is that enough to be considered successful? In what measure do these children improve? This was the paper that we did as the 5 units that were commissioned, that was then published on Lancet. But I think disappointingly, this only measured JMFM and CP-QOL, didn't measure anything else. And I don't think that this necessarily gives you the full picture of the success of an SDR. Other papers would say that is inconclusive. Yeah, it's good, but bit inconclusive. Long term, we don't know. You know, there are still question marks put in front of us. So what is the ideal outcome measure? Well, GMFCS, do they change GMFCS? Not really. So GMFCS is not necessarily an outcome, is more a classification of the candidates for SDR. Spasticity, yes, as I said, but is that enough? We know that the spasticity goes. Muscle strength could be at times unreliable, so we need to do it definitely more than once and for quite a long time. How long? I suppose the longer the better. For the mobility scores, there are a lot of variables, and in particular, if you only consider one mobility score, and the quality of life is operator dependent, and it very much depends on the expectations from the family. So because of that, and my team hates me for it, but we use all of these outcome measures. So I basically went for all of them, trying to then understand, is it one that is more significant, is statistically significant, or are some outcome measures actually even not relevant, and we waste our time doing. PD self-care scores and all the PD dominae are essential in understanding if these kids really are better. So we do the self-care and you can see how much they improve. And interestingly, the self-care, see how much it has improved from 2 years to 5 years. So the jump is even higher. I forgot to put the 10 years, but 10 years is even higher. And this is again for 3, but in particular for 4. This is the PD mobility, and again, between 2 and 5 years, they carry on improving. And really, this is data that nobody has ever shown. There is always, again, a question mark about, oh, they stop getting better at one point. When do you draw the line? I don't think we can draw the line at 2 years. It should be definitely longer than that. Then there is a variable that is often underestimated, which is the pain. Now, I am an advocate of doing SDRs for pain only. It's a one-off operation, and the pain goes on day 0 to not come back. Vast majority of the patients who were on several different painkillers schemes or still on oral baclofen or just accepting that they're supposed to be in pain, completely gone. And sometimes after the 2 years, I say, okay, have you still got spasms? Do you still don't sleep at night? And they look at me like, what are you talking about? I said, well, when you came the first time, that was your main concern. And I said, oh yeah, no, yeah, that's it. I'm sleeping throughout. So we should really consider that as one of the main indications for SDR. 6-minute walking test based on our data for as I said, for the patients who can do it is statistically significant. And again, it also improves and carry on increasing between the 2 and 5 years, and the Gillette as well. So that means their mobility, if 5 different mobility measures will all keep improving, that means that the mobility does still improve even after the 2 years cut off. So what's the future? Well, I think non-typical patients should always be considered. I'm not saying that we got to do it, but at least considered. And also in units where all the movement disorder treatments can be offered, a combination of different treatments should at least be discussed and see what the best combination for that particular patient is. We obviously need more data to be published, despite, again, in the UK being commissioned, there's no national audit, and in other units, the follow-up stops at 2 years. So I think there is a missed opportunity there. And through the International Society of Pediatric Neurosurgery, I'm trying to set up an international central data submission with few outcome measures that we know are very relevant that can then be compared and put together and have a more reliable way of measuring SDR success. So thank you. I'll stop sharing.
Thank you, Dr. Vendetta. We can have a discussion. I invite the panelists to conduct a discussion of the topic.
Yeah, let me invite Dr. Shibu Pillai to give his critical comments and ask any questions to our speakers.
Yeah, that's been an excellent presentation by all the speakers. And of course, Professor Petroni has outdone herself as usual. And she and Professor Purohit have both been my mentors when I started doing spasticity surgery. So in that sense, it's great to have both of them here in this session. And I think what I've learned from my small experiences, one thing is, as the other speakers have pointed out, it's very important to be part of a team. So the pediatrician, the pediatric neurologist, orthopedician, the physiotherapist, and the neurosurgeons all have to work together. First of all, when you set up the program, to get the patients and then to take them through the whole program requires the entire team to work together. So that's very important when you're starting a program for spasticity management in these children particularly. The second thing, as Dr. Petroni mentioned, is that we need to, and I think Professor Purohit also was repeatedly mentioning about how we need to select the right patient for the right procedure. So particularly if you're doing a selective dorsal rhizotomy, ensuring they have adequate strength before we reduce their spasticity is an important part of the decision-making process. Other important thing I realized is that when we speak to parents, we need to ensure that they keep their goals realistic and that we come to a common agreement about what we are going to hope to achieve from the surgery we're going to perform. Because if they're not very clear about what to expect after surgery, then we may end up with arguments and problems later on. Finally, we need to take the child into our confidence. And particularly with regard to physiotherapy after surgery, which is a very important part of the management, we need to make sure that the child understands what the exercises are going to be, what are the things they need to cooperate with, and how much effort is required after surgery. Because if they don't cooperate with that particular exercise program, then all the surgery that we do is going to be a complete waste. So I think we need to take all this into account before we undertake a surgery. And I think it's something which is worthwhile doing across the country because it's quite, especially the neurosurgical community is quite underrepresented in the management of spasticity in India at present. And like Purohit sir, I think we need to take this into the community and be part of the spasticity community to be able to increase access to this service by the children who are affected by this kind of spasticity. Yeah, thanks. Thanks, Matthew, for inviting me here. It's been a good session.
Yeah, I had a query to ask to Dr. Purohit. I think the vast majority of spasticity patients are seen by pediatricians. In India, to what extent do our pediatricians think beyond the routine options towards surgical options or maybe planting a baclofen pump? Probably they may end up at medical management. And what can be actually done to motivate the boss pool actually will be with pediatricians to initiate them into seeking more advanced options?
Yes, Dr. Matthew, you are very right that first of all, these children, they go to pediatrician and a lot of awareness has to be brought amongst them also. In 1981 in Hyderabad, they have the Indian Academy of Pediatrics conference and I gave a guest lecture just by that time I was 1991, sorry, 3-year experience. And afterwards, I also became the member of Indian Academy of Pediatric. But I must say that the overall awareness regarding the team approach for these children is quite lacking because one thing is that the surgery everybody is afraid of. Second, they have got now botulinum toxin in their hand, so they do give the spasticity management at early age to these children with the botulinum toxin. Now, as Dr. Lokesh said, they have a very good team where the physiotherapy, oral medications, and botulinum toxin. And when resistance developed to this, I have seen that the cross referral from the physiotherapist, which should come, does not come usually in our country by the time they develop contracture or they go into the crouch gait. So Dr. Matthew is very correct that how again they have a disability wing also in Indian Academy of Pediatrics, but still, despite me being a member also, I do not think that the enough awareness has come in the pediatricians in our country. Over to you, Dr. Matthew.
Um, yes, we also have a huge number of physiotherapists in our country, and they in India the physiotherapist is often seen as a doctor, and the large number of patients actually rely on them to give any further advice. Do you think that a separate approach is required because they really do not come into the main medical stream? Very often they work as an independent group. They have their own associations, and the trust the patient has on them is actually very high. Do you think that there must be some form of movement to initiate them into this, physiotherapists into this, and maybe the physiatrists may play a role in this?
Yes, Dr. Matthew, that is why we developed the Indian Academy of Cerebral Palsy, where the maximum number of the members are actually physiotherapists. And as you said, to bring the awareness, this was our idea. And not only physiotherapist, we have all modalities of the management, alternative or additional therapy experts also in our platform. So, although we have tried our best to through the Indian Academy of Cerebral Palsy also, but as you have correctly said that we need to have something more. I have given many lectures in the what is called as physiotherapy conferences also. But still, I know that there are many centers which are being run even in Hyderabad also, Delhi also. But till we go and meet them and show our results, they also do not get motivated. And painful thing is that despite having contractures and pains, we usually do not get the referrals from them. Over to you, Dr. Matthew.
I think, sir, one of the thing way could forward could be that the physiotherapy colleges should have a little bit of classes. Even botulinum toxin, most of the physiotherapists say it is not required. Likewise, surgeries. So I think the sensitization at the educational level, that it has to be compulsory that these children have 1, 2 classes from the pediatric neurology, from the pediatric neurosurgeon, orthopedician as to when to intervene, what to do, show the results. Then probably in the formative years, once they are impressed, maybe it will be better.
Okay.
Yes, Dr. Lokesh, you are very right. And I tried it, say, for example, wherever I had the cerebral palsy workshops, the camps, etc., and I tried to teach them, where somehow the organizers did bring the students from their physiotherapy colleges. Say, for example, in Jaipur, Rajasthan, I did teach them, and maybe from 2001, I was almost every year I was conducting camps over there. But even then, when I have taught them everything as well as selection also, and some of the results also, which we operated in those places in the country at various places, even then, I'm not finding the referrals over there, despite their own patients or the children have improved. So, although you are very right, this should be the beginning in these places, the educational courses of the physio, occupational, and orthotic. All the three agreed upon it. Thank you. Over to all of you.
To what extent in India is there government support for therapeutic options for spasticity? Yeah.
That's very interesting. Uh, on the polio, there is a lot of motivation of the government, and they are giving lot of money, say 3,000 rupees for one case if you operate at a particular place, which I know somewhere in Rajasthan it is happening. But what actually happens to every one of you that in India still any disability in the childhood is considered as a polio, and that is another awareness has to be brought. And many children in these polio centers who are having spasticity, they directly undergo the tenotomy, which is actually nowadays in cerebral palsy, in spasticity, we consider outdated. Tendon should not be cut. But these things are happening, and I get those patients afterwards with still the clonus present. So government has to be again motivated, as Dr. Matthew you have very correctly said, by bringing awareness in the field of the childhood disability with the spasticity with the cerebral palsy. Yes, agreed. Good idea.
I had a question to Dr. Vendetta. Do you think DBS will have a role in spasticity in future?
DBS, you mean?
Yeah.
Yeah, so we do. I don't personally do DBS, but of course I share the MDT with the DBS team as well. So as I said, we do try to make the correct combination, right, of treatment for these patients. I am not convinced that a baclofen pump for spastic dystonic patients last forever. The thing is that at 16, within the 19th years of life, we do transition to the adults, so we do lose the follow-up for those patients. But the earlier the pump goes in, the less the effect and the good result is forever. And so we are now trying to switch to DBS and SDR combination for the severe spastic dystonic patients. We don't do DBS when the
normal આવી છે વિટામિન ડી બી સારું છે और પ્રોસ્ટેટ में भी કઈ પ્રોબ્લેમ નથી પ્રોસ્ટેટ में કઈ કેન્સર નથી કઈ નથી ઓકે તો બાકી जो
Sorry.
No worries. So as I said, it's not, we don't do DBS for spasticity, but we do think about DBS plus SDR for spastic dystonic patients, as I say, in particular for the ones where there is a predominant pattern, lower limbs, upper limbs.
Oh, thank you. If there are no more questions, I request. Yeah, please.
There is a question group chat for Dr. Vendetta.
Yeah.
You may ask Dr. Saurav.
Okay, great. Thank you. Yeah, thank you. Thank you so much, Dr. Benedetta. My name is Saurav. I'm a pediatric neurosurgeon. I, in fact, trained at the Great Ormond Street with Christian and Dominic. So quite a few questions. First of all, could you explain your challenges with the GMFCS grade 3s a bit more? So you said, the 1s and the 4s are better, but not the 3. But why do you say so?
Yeah, so I am only scared of the 3 as the ones that I would take the wrong decision, right? Okay. Because so of course there is a learning curve, right? So at the beginning of the service, I was doing test dose in a lot of GMFCS level 3 to really understand what their muscle strength really was. Because in some of them, they can be stronger than you think. Therefore, the result would be good, right? But some of them would be weaker than you think, right? So those are the ones that really, if when they're not on the wheelchair when they come to you, you can put them on the wheelchair, right? So that's why my level of threshold, right, for selecting a 3 is higher than with any other grade. And also, as I said, I use test dose for those and Botox injections as well.
Okay.
So basically, I want to see them, what they're able to do without spasticity or with a lesser extent of spasticity. So I would know if actually they can recruit, they can rehab, and they can put some muscle strength on and actually improve.
Right. So this is your practice even now to do a test dose of baclofen for the 3s?
Yeah, so we got better in terms of doing assessments that are very reliable in terms of muscle strength, but there will still be the one that we feel this one is going to collapse, right?
Right.
And then based on the patient, we then pick if we do Botox injection or test dose.
Okay. Okay. And one more question, possibly, revolving around the intraoperative monitoring. So I assume you use the same Phillips and Peacock criteria for the grade 1, 2, 3, and 4.
Yes.
So does the involvement of different muscle groups by the spasticity on your pre-op assessment decide what percentage of rootlets you section intraoperatively, or is it purely intra-op monitoring based?
So thanks for the question, because this is probably the most interesting intellectually, from an intellectual point of view, and practical in the end.
Yes.
So at the beginning, again, right, you tend to correlate, right, or you want to correlate what you know about the patient, about the physical exam, with what you find intraoperative and what you think they need, right?
Yes.
However, you do neurophysiology to have the most objective criteria of that, right?
Right.
So the selection I make of them is based on intraoperative neurophysiology only.
I see.
Okay.
I see.
So, and also because you need to be in terms of then analyzing your results, right? You need to be as consistent as you can be, right?
Sure.
And as objective as you can be. So the whole point of doing a selective dorsal is to understand which nerves you need to cut more or less, because there's no evidence that if you cut 50% of all of them, you will have a lesser result than being selective. You know what I mean?
Right.
So what's stopping us from doing 50% of them all?
Right. Absolutely. Yes, I agree. Right.
So I do based on response to tetanic stimulation only. So if it is 3 or 4, I cut 2/3 of it.
Okay.
If it is 2, I cut 50% of it. That's my rule.
Fair. And I'm sorry, I just had a last small question.
Yeah.
I mean, the Seattle group and many other groups have described this infraconus technique of SDR. Where they do the laminotomy below the conus? I mean, any thoughts on it? I mean, do you think there's any advantage or?
So I do below the conus too.
Oh, I see. Yes. So and anything to choose in between the two?
So the reason is, so although of course having a visuals of the dress is good, right? It's easier, okay?
That's right. Yes.
You do have neurophysiology, right?
Yes.
So you don't necessarily have to have the visual confirmation that you have the dress of L2 or whatever it is.
Sure.
By rule, I do an L1. I start with 2/3 of L1 laminectomy, leaving the first third of the L1 attached to the ligament. Okay, so that's why, to be honest, depends on the patient. Sometimes I find myself right in the middle of the conus, and sometimes it's called equina only, and it doesn't.
It doesn't matter.
Doesn't matter. As long as if you don't have neurophysiology, it matters very much, right? But with neurophysiology, it doesn't matter. And even if in some patients, some patient would have arachnoiditis, they would have a shunt, they would have had the previous meningitis, so the roots are not where you're supposed to find them. It doesn't matter. Then if you get a motor in your hand, you leave it alone. So it doesn't matter.
Doesn't matter really. And a bulbocavenosus reflux, a BCR is mandatory. You have to, I mean, in your practice, you will do it and you won't attempt it without a BCR.
Categorically.
Fair. Thank you. That's very helpful. Thank you so much.
Thank you.
Can I have some comments related to the same question?
Yes, sir.
So, Dr. Saurav,
yes, sir.
we do what Dr. Peacock procedure, that is, he started with the L2 to L5 and nibbling of the S1.
That's right, sir. Yes.
Right. So there it is very clear to see the exiting and entering nerve roots very clearly. And in 1988, we used to also do lot of electrophysiological stimulations during surgery and seeing whether it is a tonic response or clonic response, phasic response, incremental response, etc. Hours together, fine rootlets we used to. Right.
But
then ultimately, we have realized that perhaps looking to the severity of spasticity, usually when we are doing it is mass 2 or 3. So most of the rootlets are hyper-excitable. So actually, when we are going for 50 to 70% of the ablation, and when we know clinically that there is severe equinus, there we will go for S1 as 75%. But we know that the L4 is the extensor, so we do only 25% of the, but the L5 is hamstring knee flexion. So there we again go for 50 to 75%. So like this, we divide it into clinically based our criteria to the ablation here. And we do not go to the corner, so we are not that much required again, as Pettorini said about the electrophysiologically. Also, you should see, but we are with our microscope and naked eyes, we are able to see. However, please remember, most of the cases which we see in our practice have more on knee flexion and equinus. A few patients have the what is called as the hip adduction. So we usually do nowadays L4 caudal and L5 full laminectomy, and with that we go for L4, 5, S1, S2. We know that there is a positive side effects because of the international neuron firing up cephalad also decreases when you reduce the spasticity in the caudal, say S1 and L5. So hip adduction we have seen as a positive side effect that yes, it also reduces. However, we know that if still it persists after giving good physiotherapy, we go for obturator SMF in the second stage. So we have the selective fasciculotomy also in our hand. So we need not to go for a wide laminectomy or the vertically as well as horizontally. We have limited our laminectomy. So this is the
So from what
modification.
I
And one
understand,
thing
sir,
more.
so
Sorry,
from what I
one thing
understand, sir,
more.
you do L4, L5, S1. That's what you target generally. L4,
And
L5, S1.
sometimes S2, 25% only.
Okay, so L1, L2, L3, you wouldn't section generally. I mean, you
No,
would do
nowadays,
I see.
in last few months, we have done most probably 2 or 3 going up to L2 when they had a very severe seizuring and there were hip dislocations. In those cases, subluxation. In those cases, yes, we went up to the L2 also. L1 never.
I see.
Only one case I remember of Mumbai long ago in 1991, we went up to L1.
I see. No.
Thank you.
Thank you.
And I would like to, on behalf of the webinar committee, I would like to thank the panelists, Dr. Purohit. I think he would like to have one more nap. He has got woken up early.
Thank you.
Shibu, Dr. Benetta, Dr. Pavan, and Dr. Lokesh for giving excellent talks, and also for Sachin for coordinating this, and all the participants. Thank you once again.
Welcome, sir. Thank you.
And thank you
Thank
to
you.
Dr. Mehta.
Thank you, sir.
Thank you. Thank you very much.
Thank you.
No laughter?
Sir.